Please, let's begin our program. I'm going to hand it off to Dr. Abbott. She's going to start us. And again, please, just a reminder to keep your microphones muted, cameras on or off, and please hold questions until the end. Thank you so much.
Thanks a lot, Catherine. Hi, everyone. Thanks for joining today's sports medicine lecture. I'm Alex Abbott. I'm a primary care sports medicine doctor for Stanford Children's. I'll be collaborating today with Deborah Callahan, who's a certified athletic trainer with Stanford Children's as well. And we'll be discussing shin pain in young athletes. So for our outline, we'll start with some background and definitions so that we're on the same page, and then we'll continue discussing diagnosis, risk stratification, and prevention and treatment for patients with shin pain. So many times when patients have shin pain, they will suggest a diagnosis to you as a presenting complaint or a chief complaint of shin splints. Shin splints, unfortunately, if I think we advanced a slide. Ivan, if you could go back to our first slide. Thank you. Shin splints, we colloquially for the more objective term of medial tibial stress syndrome, or MTSS. This is not as concretely defined as other types of injuries can be. Most commonly, we think about shin pain instead of shin splints as the umbrella term, but shin pain can encompass MTSS. MTSS is essentially an overuse injury that's marked by periosteal edema. The periosteum is the outermost layer of the bone. This definition, though, it's sort of evolved over time and depending on what literature you look to include the suggestion that MTSS is like a pre-bone stress injury, or BSI, without the features of the lowest grade bone stress injury yet. So we have pre-diabetes, maybe pre-stress fracture. Studies in the future with the aim of objectively characterizing the progression of MTSS to bone stress injury would be helpful to confirm if it actually is like a pre-BSI. But essentially, despite our best efforts to nail down a definition, we're trying to include the specific structures, the mechanisms for injury development. This term shin splints is pretty persistently used colloquially to be synonymous with shin pain in general, with soft tissue pain like muscular strains in the front of the shin, and essentially anything other than a stress fracture in the tibia or fibula or pre-bone stress injury. I like the term more use of the term periostitis because it tells you we're focused on the periosteum of the bone, the outermost layer, but this is not a term that patients are usually familiar with. So patients who are researching their shin pain online will often self-diagnose with looser definitions, and they'll come from a starting point of poor understanding. Further, when we're using the term shin splints interchangeably with exercise-related shin pain in general, that sort of blurs your differential diagnosis for shin pain into one specific etiology. This can be problematic because the separate items on the differential for shin pain require slightly different treatment emphases. So on the right, I've sort of dissected the anatomy of the shin. Our pain culprits might be the muscles that control ankle motion, especially dorsiflexion, or the muscles that control foot motion, especially toe extension. So those are our muscle groups in the front of the shin. We could actually have an issue with bone stress resulting in periostitis, that's our MTSS, or we could have a true bone stress injury that we've progressed to, where you start weakening the cortex of the bone, or we start seeing marrow edema. Finally, there's a rarer etiology on the differential for shin pain of exertional compartment syndrome that commonly can present with shin pain. This is essentially where blood flow through defined compartments in the leg is compromised by increased pressure during exercise. But separating these etiologies is really important. Patients will essentially start with, on their Google searches or now ChatGPT, shin pain equals shin splints, and they don't respect or fear the potential initial symptoms of a true bone stress injury. Bone stress injuries essentially come about when the adaptations to loading bone can't outpace the breakdown of the bone during loading, such as training. This sort of imbalance can occur with inadequate nutrition, excessive loading when we're exercising, or inadequate recovery periods between your training sessions that don't allow the adaptations to occur by the time you're running again. Half of bone stress injuries, 50% of them occur in the tibia, which is the most common location for this injury. So very important for our talk on shin pain. Bone stress injuries are most common in runners. We think about gymnasts, basketball players, soccer players. So think about high impact, repetitive impact, and then especially if an athlete's description of their ramp up of activity or exercise volume, especially now, school's getting started, fall sports. So we have some couch potatoes this summer. If our ramp up looks like 0 to 100 too quickly, then we should scrutinize them as well. The most common athlete types with bone stress injuries also represent sports that emphasize leanness. So we think about running, gymnastics, dance. There's a well-described association with low energy availability, menstrual irregularity, or other hormone imbalances for male athletes, and then with low bone mineral density that helps that makes it so that athletes are who are trying to emphasize leanness, they are more predisposed for risk for bone stress injury. This used to be called the female athlete triad, but we now refer to this as relative energy deficiency in sport, or REDS, because this can affect male athletes as well. In pediatric patients, we most commonly see bone stress injuries in our adolescent populations. So if you have a teenager, maybe they're focused on leanness in some way, either for the aesthetic or for the performance. They're engaged in the sports that we discussed. They're complaining about pain near the most common site for bone stress injury in the tibia. You should definitely profile that patient. When you're thinking about ruling out bone stress injuries, starting with an X-ray is helpful as a screening tool, but MRI helps to grade and confirm your diagnosis. The grading then allows you to improve your risk stratification, your prognostication, and management planning. And then it will also be really important for guiding nuances of rehab and return to sport, such as the initial rest time that's needed, and then how conservative you are in physical therapy. So in addition to characterizing a bone stress injury of the shin as high or low risk, depending on the specific location, grading based on MRI findings is associated with the time for return to sport progression. So the MRI is very helpful. Full discussion about bone stress injuries head to toe in terms of which sites are high risk is out of scope for the shin pain talk. But for the shin, your high risk site is specifically the anterior tibia. The lower risk sites in the shin include the posterior medial tibia and the fibula. These are more likely to heal with just proper rehab, and they're less likely to require surgical fixation. And then finally, as you can see on the right, we're moving away from calling every bone stress injury a stress fracture. This term is starting to be used more frequently, more objectively for bone stress injuries that actually have linear signal change that indicates a fracture line. That would be our grade 4 bone stress injuries. So bone stress injury treatment, we start with rest. Essentially, we're putting the fire out and allowing the initial healing to occur. Once the pain has resolved, we can assume that a patient has started healing clinically and start challenging the bone to strengthen with a gradual loading progression. During the initial rest phase, 3 to 6 weeks typically. Patients may be more on the longer side of that. They may need more rest. For patients who are still symptomatic after 3 weeks of rest, if they have a higher grade bone stress injury at the time of their diagnosis, and or if they have a bone stress injury in a higher risk site, such as the anterior tibia in our Shin case. If a patient has a high risk site and you want to optimize your chances of healing, using a cam boot, a walking boot, and or crutches to sort of fully shut down load on the bone can be really beneficial. If the patient has a low risk site, they don't have pain with weight bearing, and you want to sort of optimize your rapport with the patient to encourage buy-in, encourage sticking with recovery with you for the long haul, you might consider deferring the boot and crutches if you don't think it's going to add much to your recovery. The boot can also serve as like a low jack, like a immobilization for a patient who won't adhere to rest without something physically slowing them down. So if you prescribe rest, but your patients are reporting non-adherence when they follow up, maybe the parent's not really understanding what complete rest means for somebody who doesn't have a device on. Putting a cam boot can provide a sort of tangible reminder. They have to actually break the threshold of removing that to start running around and things like that. These photos on the right show how even though you can't grade an MRI on the left with the X-ray, you can catch it when you're screening for it in the clinic. And then the picture on the right shows that dreaded black line of the anterior tibial bone stress injury. And then the reason why it's dreaded right behind it. This patient required fixation for recalcitrant bone stress injury. When patients are diagnosed with bone stress injury, I'm pretty transparent about the planned return to sport protocol in its entirety to try and set expectations early, avoid surprises, and maintain trust with the patient. Unless I'm worried that a patient will preview the next phases and then tempt them to start taking shortcuts, I show them what phases are in anticipation, and then I explain that the minimum time to complete all of our phases for complete return to sport is around 4 months. I also explain that pushing through pain and trying to expedite the process can paradoxically make return to sport take much longer. Going through the phases once properly is the goal, and having stronger bones at the end from going through these phases slowly and gradually loading the bone and allowing those adaptations, it's definitely preferable to the endless build-up and breakdown cycles that's associated with completing the phases over and over again because we're ignoring symptoms or we're moving too quickly through the protocol. The Sisyphus allegory is the one that I relate to patients, the one that comes to mind the most. This is the story, Greek mythology story of a man who's doomed to push a boulder up a hill only for it to roll to the bottom endlessly. So that's essentially the fate for athletes who don't tell you about pain and they continue their progression inappropriately. So you can see on the left, this is our first phase, which is the unloading phase. We described that previously, between 3 to 6 weeks, typically for complete rest at the beginning. And then our next phase involves low impact cross training and strength training with the end goals of strengthening the muscles that support loading through the shin and having a bone stress injury site that's healed and remodeled enough that pain is not present with longer distance walking. And then we can go to the next picture. Phase 3 starts gradually increasing your load through the bone with jogging and plyometrics. Okay, show you the next one. And then phase 4 is the return to run. This is the favorite phase of our athletes. Return to running or return to goal activities if we need to modify it for non-runners. So you might be asking, why does an MTSS talk, a shin splints talk, a shin pain talk have so much content on bone stress injury? So when I think about patients who present with shin pain, similarly to a patient who presents with something like a headache, chest pain, a fever, the safest practice is usually to rule out your worst case scenario. So for your headache, you want to make sure they don't have a brain bleed if they came in with a traumatic headache. If they're coming in with chest pain, you want to make sure it's not cardiac. If they're coming in with a fever, you want to make sure it's not a serious infection. I think about it in the same sort of practice. We should rule out bone stress injury first when that's high enough on our differential. Once you rule that out, then you can more confidently diagnose the more benign MTSS and then proceed with treatments that allow athletes more freedom. So less strict restrictions, pain as your guide instead of these strict timelines that I was describing, things like that. Some of the clues that would support MTSS as your diagnosis, either before or after your bone stress injury rule out, that start in the history. So if a patient says that they've got pain that's exacerbated during exercise, this is not unique to other items on your differential, but might clue you in. There's anecdotal reports that bone stress injury seems to be more commonly associated with nighttime pain than MTSS, but this is not studied enough objectively to make this a rule. On exam, diffuse pain is more reassuring for a benign diagnosis of MTSS. And then if you have more focal pain, you should be more concerned for a specific bone stress injury site instead of the diffuse sort of periostitis of MTSS. There's suggestion in the literature that 5 centimeters or more should be considered diffuse or a broad location along the shin, but I couldn't find any specific literature that related that 5 centimeter rule to the likelihood of bone stress injury versus MTSS. So this number seems a little bit arbitrary, but it helps give you sort of a framework to start from. MTSS pain should also be reproducible with exercise, but not reproduced in your clinic with non-weight bearing foot and ankle motions. You'd be more thinking about muscular strains, or if someone's doing repeated calf pumps or ankle pumps in your clinic and they're able to reproduce symptoms, then you might think about exertional compartment syndrome. But those are different items on your differential that you should think about. For imaging, x-rays are good for screening like we talked about, but MRI for MTSS, if you are checking it and you're ruling out bone stress injury, you don't see a focal site, you may actually see that diffuse periosteal signaling instead of the vocality of the bone stress injury. And then if they have a muscular strain on your MRI, you'll probably just see signal in the relevant muscle. I had a really excellent case. This helps to illustrate MTSS versus bone stress injury quite well. So we start with this 15-year-old ballet dancer who presents with shin pain. It's left worse than right. She's diagnosed with a fibular bone stress injury based on X-ray and MRI. And then she starts a period of rest from impact, followed by bone stress injury return to sport progression. You can see on the X-ray her fibular signal shows some really subtle changes if you look over the tibial border of the shaft of the fibula. So the tibial side of the fibula, you can see it kind of gets hazy. You don't really have the clean demarcation of the cortex that's more easily drawn. You'd have to get your sketch pen out and draw that like hazy part on the inside. And then on the MRI, you can see the skinny but bright white fibula on our cross-section view there, and then compare that signal to the thicker tibia on the top. That clues us in that there is bone marrow edema, especially when we're contrasting it with the normal tibia. So for this slide, I'm giving you the initial presentation through diagnosis of bone stress injury on the same slide. That means that this is not the interesting part of the case. So we'll move to the next slide. This patient's symptoms resolved after the rest period, but then after starting plyos in phase 3, she returns for concern about recurrent shin pain. The MRI we get is reassuring against recurrences, and then we see instead periosteal and muscular edema. It's suggesting our shin splints or our soft tissue stress, MTSS. Interestingly, she also shows some muscular edema that's posterior medial to the tibia. And then on the medial border of the tibia, you can see the periosteal edema. Essentially for this patient, this case, on her initial presentation, she showed a clear fibula bone stress injury without any concurrent diagnoses. And then on her follow-up presentation, she demonstrated nearly every other item on the differential for shin pain with muscular edema, periostitis. She's got MTSS and the soft tissue. She had everything except for exertional compartment syndrome on her second presentation. But even though she didn't have a bone stress injury on the follow-up, I was proud of this patient for following up with recurrent shin pain rather than pushing through the protocol. And then the evidence that we had from her new MRI that her bone doesn't need another shutdown period for a true bone stress injury allows her to progress through the protocol with confidence and progress through it just one time. To contrast with the treatments that we talked about for bone stress injury, just briefly, compartment syndrome can require surgical intervention such as fasciotomy. Muscular strains can benefit from physical therapy for specific muscle groups. And then MTSS or periostitis is often sort of less formally treated with rest and gradual return to play with less strict parameters. We think about a range of 2 to 4 weeks after rest or relative rest. I always hope that when I'm talking to patients that when I tell them, oh, all you need is rest, that's good news, but they usually look at me like the athlete on the right. Most patients with MTSS, they'll have this sort of license or freedom to return as tolerated. But at your discretion, if you're feeling like you need to shut an athlete down for a set amount of time, use a cam boot for pain with weight bearing, things like that, you may need to escalate your treatments. But in general, we're a lot nicer about our treatment plan than we would be for bone stress injury. Again, I'll emphasize the zoom out sort of motivation is that with bone stress injury, we're trying to avoid surgery. So if that is our sort of motivator for the patient or the parent to adhere to our protocol, that Sisyphus allegory can get sort of abstract. As surgery is quite a tangible thing to warn about. But I'll emphasize for this talk in general, it's crucial to see sort of past the patient's maybe self-diagnosis. I just had yesterday a patient self-schedule for an appointment with me with the chief complaint of shin splints. So you can imagine if a patient sort of comes into your clinic expecting for a talk on shin splints and you're going through the differential of shin pain instead, it's really important that MTSS is the correct diagnosis on your broader differential and you're helping to reframe that conversation. So this is essentially, this slide encompasses the short version of treatment for MTSS. Deborah is going to talk about how risk factor identification can tailor rehab, some footwear considerations, and then some rehabilitation specifics that are related to the MTSS treatment in more depth.
All right, guys, getting into some of the risk factors associated with specifically shin splints or MTSS. There are some risk factors that overlap for tibial bone stress injuries and MTSS. So I'm gonna separate them because there's some that are unique to each condition. Being female is associated with risk of both. Females, some of the literature states that females can be at twice the risk as males are. And then for shin splints, a higher BMI is actually going to be associated risk factor, unlike bone stress injuries where you're actually going to it's going to be a reduced BMI. In addition to being a risk factor, the increased BMI for shin splints in particular seems to be a little bit, it seems to also cause these patients or potentially these patients are going to take longer to recover from it. So they may need a little bit of a longer period of rest or a more gradual return to their activities. And then a history of shin splints, that one just pops up pretty consistently. And then the kind of important one is pronated foot anatomy is kind of one of the more anatomical findings that is frequently associated with MTSS. Or some of the literature just reports it as like a positive navicular drop test, which is essentially just looking at the displacement of that bony prominence, the most prominent aspect of the navicular when an individual goes from a resting position to a weight-bearing position. A little bit of like debate in the literature about what exactly is a positive, but like a 0.5 centimeter of displacement is typically going to be considered a positive. I don't know how many of us are pulling out a ruler or a tape measure or anything to actually measure this, but I feel like if you just, 0.5 centimeter is a little bit easier to eyeball, and you'll notice if somebody's dropping significantly when they go into a weight-bearing position. And then as far as extrinsic risk factors, they're relatively similar. Faulty running mechanics, which I'll get into in the subsequent slides. Training errors, it's like Dr. Abbott said, it's essentially like, too much, too fast, too soon. And then the level of athletic experience. So the more experienced an athlete is, the less likely they're going to be to develop this condition. And then, as we know, kind of some of those novice athletes that jump into it. This is common in like a lot of the research is done on like military recruits. And I have personal professional experience with military recruits, and super common injury because so many of these kids come off of the couch straight into marching for hours and hours and hours or running for a really long time. And then all of a sudden their shins feel like they're on fire. So it's a really common thing to see, kids that go from doing almost nothing to suddenly doing a lot to develop this condition. You can advance the slide, Ivan. And then for bone stress injuries, the most common and like really easy to identify risk factor is just going to be a previous history of a bone stress injury. So we can, it's easy to screen for. It's universally accepted as like a risk factor for future bone stress injury. And I'm talking about like a previous bone stress injury anywhere. And so the benefit to identifying whether they just had a prior bone stress injury is that it's very likely that these individuals are also going to have some, or they're already going to have some of these other risk factors. So they may already have a reduced BMI or have disordered eating or energy deficiency or menstrual disruptions and things like that. So the prior history is probably the biggest one. And then similar as far as extrinsic factors, sudden training changes. Training changes can be increases in volume. They can be changes to the terrain that they're training on, or just a new activity that they hadn't been doing previously, and all of a sudden they're doing it a lot. Those type of things are just, they kind of just make you kind of perk up a little bit to like whether they're going to be at an increased risk. I like this diagram here because it really like shows how having more risk factors compounds the percentage of their overall risk. So being female is already starting off with like an increased risk relative to the male, and then you start adding some of these other individual risk factors, and it really starts compounding on top of each other. And then the males don't have quite as many things to worry about with regard to a bone stress injuries as females. And then Dr. Abbott mentioned previously some other risk factors, specifically like participation in lean sports or sports that sort of emphasize leanness. Those are just individuals that we just should be a little bit more aware are at an increased risk as well. We can advance the slide now. So getting into running mechanics a little bit, I like to discuss sort of, so I know there's some athletic trainers here, and you know, so some of this might be applicable and some of it might not be. But watching how somebody's running will give us a good insight into kind of how much stress they're putting on their tibia, especially. Abnormal running mechanics are associated with shin splints and tibial stress fracture. Specifically, a low step cadence is going to be correlated with increased stress at the lower leg. An exact number, you know, I dug through a lot of literature to see if there's like an exact number that's like a cutoff. There's nothing that I could find, but in our lab, in our normative data, in general, like 170 to 175 steps per minute is going to be sort of where, at a minimum, where we would prefer to see our patients. It's lower than that, and most of the literature is associated with increases of stress. I talk about cadence and overstride sort of together because they typically go hand in hand. If we notice somebody with a really low step cadence, they're typically going to demonstrate some degree of overstride. Overstride is essentially just referring to the distance between the center of mass and the foot at initial contact. So the greater, like in this picture here, the greater that distance is between that heel and the center of mass, the greater the degree of overstride. And that is pretty well documented to influence the knee extension moments and the braking impulses. So the other thing you'll see is a longer step length. Obviously, if you're overstriding, your step length is a little bit longer. And then down at the foot and ankle, a lot of these will kind of go together. Down at the foot and ankle, when someone is overstriding, you're going to notice obviously that rear foot strike, that really dorsiflexed foot. And then if you have the opportunity to get some 2D video and looking at it from the posterior view, a little bit of a lag in that like eversion in that rear. We all go into some degree of eversion when we run, but they will demonstrate like a longer duration of that rear foot eversion, commonly, especially in like MTSS. And then the increased tibial angle is essentially just the tibia is when their foot hits the ground, it's sort of in this like reclined position where the knee is ending up behind the foot, and that's just causing a lot more anterior to posterior absorption, force absorption, and that type of force is it's like significantly more costly than a vertical force. You can go to the next one, and then up at the hip and knee, like I said, knee extension at contact. I like this picture here in the A box that pretty much demonstrates like exactly what I'm trying to describe. You can see his foot, how far out it is relative to the center of mass, especially compared to the individual in the B. And you can notice how significantly more dorsiflexed his foot, his ankle, his knee is significantly more extended at contact. So that's just like a pretty good demonstration of like a more optimal on the right and then a less optimal running pattern on the left. And obviously collectively, all these characteristics are increasing braking forces, and those are significantly more costly than vertical forces. In the frontal plane, the hip adduction and the contralateral pelvic drop, hip adduction also correlated with those bone stress injuries and medial tibial stress syndrome. So this, you can see in this individual on the bottom, that sort of tipped pelvis that you'll notice on the side dropping down in the weight bearing position in the mid stance space. Yeah, so that's kind of a summary of all the running mechanics stuff. You can go into the next one now. Like Dr. Abbott kind of already discussed a lot of this early phase rehab period. Some rest is going to be necessary. Typically 2 to 6 weeks, really depends on the severity and the location of the injury. You know, obviously a little bit different talking about just MTSS versus a bone stress injury, and as she said, like kind of the strictness of this early phase. In that early phase, obviously you're going to avoid any high impact activities or anything that's exacerbating symptoms. With shin splints, you can probably get away with like a little bit of discomfort with some of the cross training stuff, but really with the bone stress injury, you shouldn't be dealing with any pain near the fracture site. You want to avoid any any painful or symptom-inducing activities, but you also want to do your best to maintain cardiovascular fitness. You're going to do that with basically low impact activities, cycling, swimming, but importantly, making sure that you're still monitoring symptoms throughout all of the cross training, just in case like a patient might be having pain during that, and you should be backing off a little bit. This is usually safe even for those bone stress injuries, as long as you're really being careful about monitoring symptoms. And then, yeah, the walking boot, we're generally going to leave that up to the physician, whether, and it's going to depend largely on the severity and the location of the pain. And then as far as like some modalities that we patients may ask about, orthotics are one of those things where it's pretty indicated in individuals, especially with the splints or the medial tibial stress syndrome, if they have that positive navicular drop, or the pronated foot anatomy. Orthotics are helpful for that, and it is pretty well documented that they do a decent job of relieving pain in those individuals. But I would be careful to like recommend them kind of more broadly than that if it's not really indicated based on that foot anatomy. And then the low intensity pulse ultrasound for bone stress injuries, a lot of really encouraging evidence lately to support the bone remodeling that it helps with. So that's kind of another modality that is pretty well documented to be helpful. And then kind of on the lower end, lower level evidence is like the other stuff like ice massage, iontophoresis, shockwave therapy. It's pretty hit or miss in the literature. It's one of those things where, like, especially ice massage like that's some patients just really feel like that feels really nice. And I think if you're not doing any harm with some of these things, it's probably okay to add them, but understand that they shouldn't probably be the core of the treatment, because they're just not really that well established in the literature. And then especially with bone stress injuries, referrals are possibly going to be necessary to other specialties to address any other nutritional, energy, psychological sort of conditions that they may be dealing with as well. As far as rehab, so some studies have seen or shown that weakness and fatigue of the foot and ankle muscles is associated with like an increased pronation during running. So a good rehab program for shin pain is generally going to include strengthening of the lower leg muscles. It's also beneficial that if you have a patient who's currently non-weight bearing, a lot of these exercises can be done in non-weight bearing positions. Some of these foot intrinsic sort of strengthening, the arch doming, they're not like, the evidence to support them isn't super strong, especially when it comes to reducing pain. However, there is evidence that they help to strengthen the arch. So while a lot of these studies didn't see a lot of reduction in pain with the addition of these exercises, they did see improvements in the dynamic arch index and quality of life scores and things like that. So it is still beneficial to add these, and it's a relatively easy to, like, especially like in clinic, to like have a home exercise program. You can walk them through a lot of these exercises pretty easily. They're pretty easy for them to do on their own. So I think that they're a helpful addition, certainly. Hip abductor strengthening. Again, hip abductor weakness is loosely correlated with shin splints and BSI, but there is pretty strong evidence that increased hip adduction during the running gait is associated with these things. So sort of the logic is that if we get those hip abductors a little bit stronger, hopefully they're not going to go into quite as much of that hip adduction when they're running. And then we can go into the next slide. So BSIs especially, I wanted to sort of share this this graphic because I think it's important to understand, like the lower risk BMIs, they can be loaded in a way that is considering the injury and still loading gradually. The important thing to recognize with a BSI, especially compared to shin splints, is that we are never pushing through any pain when we're doing anything with tibial bone stress injury. So we're not pushing, unlike soft tissue injuries where you can really generally get away with like a pain level of maybe a 2, a 3, or 4. You really should be at 0 all the time with a bone stress injury. So if an athlete is reporting even a little bit of pain at the fracture site or near the fracture site during cross training or during their strength training or during their rehab or whatever, it's a pretty strong indicator that the fracture site's been irritated and things need to be modified or they need to be stopped. And then next slide, Ivan. Strength training, we're big proponents of strength training. It's typically safe to start early in the rehab process. Again, as long as you're respecting the limitations and the current restrictions that the athlete or the patient has. Again, exercises should never cause pain at the site of injury. A good strength training program should include strength, endurance, and balance. And again, just really important to monitor symptoms throughout. This chart is really just showing sort of a progression of how you can take one exercise from being a non-weight bearing exercise or an easier exercise and try to challenge a little bit into, just going from a seated foot core to a standing foot core, a double leg to a single leg. And obviously, if you jump somebody over to, for example, from a goblet squat to now a single leg squat and they start experiencing symptoms at the injury site, then you'll just kind of have them back off and go back down to the goblet squat. But generally, these exercises are going to be safe as long as you don't have those higher severity fractures. Next one. So the return to run phase, ideally prior to starting, and I know that Dr. Abbott talked through a lot of this, so I mostly am just hoping to get kind of a more overall, make sure that to give you guys like the components of a good return to run program. So before we start the return to run program, we're generally going to start sort of gradually already increasing things a little bit. What I mean by that is like if somebody's only been doing something like cycling, we may sub cycling with like the elliptical where it's still somewhat weight bearing and there's maybe a little bit of impact but not very much. And that if they're that's kind of an in-betweener, and then or even like an Alter G or a zero anti-gravity treadmill, something that's like in between running on land and cycling or swimming. And then once they're basically pain-free for 5 consecutive days with activities of daily living, then we want to make sure that they can walk for at least 30 minutes without pain. If they can walk for at least 30 minutes without pain, then you can generally start the return to run progression. We have added layers of like movements that in our protocol that we also want to see them do without pain. So like the single leg heel raises, single leg squats, jumping on 2 legs, some single leg jumping, and then just like jogging in place for a minute. If they can like do all of those things and they're not reporting any pain, then you're going to be much more confident about their ability to start the return to run program. And then the actual return to run program is essentially just replacing walking with periods of jogging and gradually increasing the amount of jogging time gradually. 5 to 10% increase a week is generally going to be an okay sort of range. And then what you really want to make sure you're doing is avoiding increases in bone loading. There's there's evidence that if the more intense exercises really load the bone much more rapidly. So it's going to be generally just wise to increase the volume first before you increase the intensity. As you progress through, we use kind of some soreness rules or some pain rules. And in general, if they have pain at a certain phase, then we're going to want to stop, rest 1 full day, and attempt that same phase. If the pain is persisting at that same phase, that we generally are going to say you need to go back and check in with your PT, you need to go back and check in with your physician, make sure that something hasn't gotten worse, and we're still kind of on the right trajectory before we start progressing them any further. Yeah, and then gait retraining, it might be a little like, I don't know, outside of the scope, but I still think that we can at least educate patients on kind of what is a more optimal gait. It is important, though, to recognize that there's no perfect or ideal running form for everybody. Our anatomy makes it so that all of our running forms are going to look a little bit different. But there are like a few things that we want to at least optimize. And the biggest one is going to be, and the easiest one really to manipulate, is step cadence. Step cadence is pretty well supported in the literature to have lasting effects and lasting changes to running gait. So generally, we're going to aim for an increase of like 7.5 to 10% from whatever they were normally at. And you can use, I'll sometimes tell patients to use metronome apps, which is like super boring. But like if that is pretty well studied that it works, but like the other option is really just using music or high tempo music. The research really does support that, as kind of silly as it sounds. They have studied it to demonstrate that we pick up our step cadence to the beat that we have kind of going through our ears. So I generally, especially in our population, they tend to like that a little bit better. And there are some like playlists in like Spotify where you can ask for a playlist that's like 175 or 180 beats per minute, and it'll just play you songs that it sticks to that beat. Increasing step cadence is great because it really, without needing any other cueing, it seems to improve the other biomechanical factors. It shortens the step a little bit, which is going to cause the patient to probably keep that foot strike more beneath the hips, which is more optimal. And it may naturally cause them to adjust to a more forefoot strike. And they'll bend their knee a little bit more. As far as like telling them specifically to adjust the foot strike, that is not as well supported in the literature. Some of the literature shows that when individuals switch from a rear foot strike to a forefoot strike, they actually had new pain in their foot or elsewhere. So it's not always the best. It's not the best advice for everybody, but if you tell them to just increase their step cadence and they're naturally kind of going into a more forefoot strike, then, as long as it's not causing pain, that's probably fine. But I'd be careful to advise everybody to adjust to a more forefoot strike. And yeah, that's pretty much it for that. As far as footwear, I'm sure patients ask all the time, like, what shoe is the best for me to run in and what shoe should I be wearing? And there is no such thing as the best shoe for everybody, even though, there's plenty of companies who might tell our patients that this shoe is going to take all their pain away, or they're never going to, like, it doesn't work that way. And most of us are going to select the shoe that is most appropriate for us based on comfort. That's described in the literature as our comfort filter, which essentially just says that we choose a shoe based on what feels good. And what feels good is generally, for most of us, going to actually be protective in itself. The literature sort of shows that we pick the shoe that's comfortable, and when we run in the comfortable shoe, our risk of injury reduces. If we pick a shoe that we deem as uncomfortable and we make ourselves run in it because coach said that this is the best shoe, our risk for injury increases. So we are naturally going to select a shoe that is better for us. The one kind of group that may be indicated for specifically a stability and motion control shoe is going to be the group with the positive navicular drop test or the pronated foot anatomy. They may benefit from that added support in the arch. And then obviously replacing shoes every 300 to 500 miles. That is one piece of advice I would definitely give patients. It's documented that the cushions and they start getting distorted as early as like 200 miles, and the distortion, some of the literature has up to 50% of distortion at 200 miles. So they start to wear out pretty significantly after you hit that higher mileage. And the preferred movement path, similar to the comfort filter, it essentially just says that like when we switch from one shoe to another, we still use the exact same mechanics. We don't really change the way that we distribute load. We tend to go right back to whatever is our normal and preferred mechanics. So that's why it's super advisable to like, you're not going to see a big difference between one shoe type and another. And then finally, as far as prevention, I would say that screening, especially for bone stress injuries, screening for a prior bone stress injury is going to be kind of the easiest preventative strategy. You will easily identify somebody who has a prior bone stress injury, like I said, likely has some of these other characteristics, or at least one of them, whether it's menstrual dysfunction or REDS, or they're just keen to really high running volume. That's a very easy way to identify individuals who are probably at an increased risk. And then, obviously, if they have some of these other characteristics, making sure that we're referring as necessary. We want to try to establish strategies for some of these people, especially like us athletic trainers, like trying to identify these individuals and establish some strategies preemptively for those people with the known risk factors, whether that's referring them and essentially collaborating with multiple the specialties as necessary. Hopefully we have some of that support to help implement some of these things with our athletes. I know that can be a little bit tricky, but sometimes for physicians, the athletic trainer can be really helpful for implementing some of these changes or some of these preemptive management strategies. And then educating patients on optimal training for injury prevention. I think that one's really, really important. Specifically, you want to advise patients to make sure that they're avoiding sudden spikes in their training volume or sudden changes in their activity type or the terrain that they're using. And then ensuring that they take at least one full rest day per week. And then finally, adding plyometric training will be beneficial for strengthening bone. We do recommend plyometric training even to our runners because it's really helpful for making the bone stronger. You want to progressively increase the loads gradually. It is important to consider that the plyos are increasing loading, so the rest of the program has to be adjusted accordingly to account for that increase in volume of loading. And then obviously if they're new to plyometrics, you want to start really slow and low, and then make sure that you're not doing too many repetitions or too many contacts per session. And so few repetitions per session, kind of sparsed out throughout the week over several sessions versus like a lot of reps in one day. And that's all we got. The last pages and references.